Sir, Ravi Edwin sir, because of last minute thing is not able to come. So, and the replacement speaker for Professor Ravi Edwin sir. So, with this, I'll start my thanks to Dr. Calwin Hospital Management for giving this opportunity. So, heart failure with preserved ejection fraction. So, earlier terminologies like diastolic heart failure has now become absolute. Now it is being called as either preserved ejection fraction or a mid-range ejection fraction. So, the current management strategies. So we need some definition for heart failure. Once we have defined what is heart failure, we want to classify it. We have to stage the heart failure and diagnose once when we have a heart failure that's reduced ejection fraction or preserved ejection fraction. And once when you have ruled out reduced ejection fraction, you want to go with management. So I'm not going to the physiology of hemodynamics, but being given the topic as management, so I will substantiate my talk with some few trials and guidelines. So, any patient with heart failure should have some symptoms or signs of heart failure, either structural or functional. Along with that, there should be some evidences like elevated natriuretic peptide or objective evidences of a pulmonary or systemic condition. So, this slide gives us a clear view about what is heart failure, what is the definition. So, I told initially about the definition. There are some few stages whether the patient is at risk for heart failure. It's a pre-heart failure or it's in an advanced heart failure. Most important thing is the classifications. Once when you have made a diagnosis of heart failure, ruled out not cardiac causes, then you want to know whether the ejection. So echocardiogram must not become a part and parcel tool of any clinical medicine. It's not being considered as an additional tool. So to diagnose heart failure with preserved ejection fraction, we want to have a basic echocardiographic tool. So once we have classified whether it is a reduced ejection fraction, mid-range ejection fraction, preserved ejection fraction. So these two both go hand to hand because you want to know that whether the ejection fraction improves from 40% to 50%, then we call it as improved ejection fraction. So with this, I'll go in more detail about how to evaluate, manage heart failure. So whenever we say heart failure, it means that the end-diastolic pressures have increased. It means that the systolic function is normal, the diastolic pressures have been elevated. So how are we going to non-invasively measure the left ventricular end-diastolic pressure? It is by an additional tool apart from the early diastolic free velocity of mitral valve as well as the tissue doctor. So when I have an echocardiogram report, the tissue doctor stating that more than 50, we know that the patient is in diastolic heart failure. And now it is being called as preserved ejection fraction heart failure. So, in addition to it, we want to know about the left atrial size, left atrial volume, as well as the LV mass. So, any complete echocardiogram with the normal ejection fraction to rule out reduced preserved ejection fraction or a mid-range ejection fraction should have a left atrial size, left atrial volume, a left atrial volume index to the body surface area, as well as a LA strain. LA strain has been recently included in the new echocardiographic guidelines for management of preserved ejection fraction. So, once you have put in a diagnosis of heart failure with preserved ejection fraction, there are a lot of scores. Like atrial fibrillation, we talk about charts to VAS score. We also have couple of scores. One is from the American Heart Association, other is from the European Society of Cardiology. So we have a H2FPEF Score as well as HFpEF Score. So these tools guides us, in what stage of heart failure are we dealing with some sort of a heart failure is going to improve. So we just go into few details about what this mnemonic stands for. So we have a body mass index of more than 30, the score point goes to 2 on 2 antihypertensives, again the point goes up. Atrial fibrillation points is 3. Pulmonary artery hypertension, echocardiographic PR velocity is more than 2.8 meters per second, then have 1 point. Elderly patients more than 60 years in men, 65 in women, again 1 point. Filling pressures more than 9. It's actually more than 8 to 15 is borderline. Anything more than 9 is considered with 1 point as per this European Society of Cardiology's HFpEF Score. So more than 6, we know that, the score more than 6, we know that it is going to be a preserved ejection fraction. So the other score is from the American Heart Association. So this mnemonic stands as pre-test assessment, echo and natriuretic peptide score, functional testing in case of uncertainty and final etiology. So here, just look at the right hand side here. We are talking about a lot of numbers here. What is more important here? EA velocity more than 15. Anything somewhere between 9 to 14 is being considered at 1 point. And now we have the left atrial volume index to the body surface area, left ventricular myocardial mass, then we have the relative volume. I'll be going to explain in the next few slides about these three parameters, and that is why it is more important because we have included echocardiogram apart from the blood markers like natriuretic peptide score also here. So once this is done, then we have like how we do an exercise stress test. We also have something called as a echocardiographic stress test where we have a diastolic stress test in specific where a proportionate increase in the E velocity along with the EA velocity. If one goes up and one goes down, then we know that the ratio goes down. We know that the diastolic heart failure is present. Then finally we have the imaging here, which it's not a part of the usual assessment, but when we have something like cardiomyopathies, we are talking about some sort of infiltrate cardiomyopathies when we do it. So, what are the risk factors with heart failure, preserved ejection fraction, advanced age group, overweight, obesity, metabolic syndromes with along with diabetes, physical inactivity, deconditioning, arterial hypertension, and other atrial arrhythmia, other atrial or ventricular arrhythmias. So this slide keeps repeating at least 3 times in the subsequent slide. The reason behind this, we have the major criteria as well as the minor criteria. Any major criteria with more than 2 points, and then it falls into the category of heart failure, preserved ejection fraction. So I just want to go through 1 or 2 things here. That is, the tricuspid regurgitation velocity of more than 2.8 meters per second. Here, anything left atrial absolute number more than 40. Sometimes we, an echocardiographer might not put the body weight and all those. Anything more than 40 ml is considered a large LA volume. NT-pro BNP with atrial fibrillation, without atrial fibrillation. Anything more than 400. We keep it something like that is considered an elevated NT-pro BNP. For sinus rhythm, probably a little less. For atrial fibrillation is more than 660. So with this major criteria, we have some few minor criteria. When it falls into the borderline between 9 to 14, somewhere between 30 to 40, somewhere between 130 to 135 to 200. So these are the few things or the minor points. Adding on to it, anything more than 5 points, then it goes into the criteria of absolute preserved ejection fraction. And if it is between 2 to 4, then we have to do a diastolic stress test. Like, low stress test, we measure the E velocity, EA velocity, and then get this 2 to 4 points to 5 points to ensure that you are not missing out a diastolic heart failure or a heart failure preserved ejection fraction. So now with the ACC-AHI guidelines, we just come with heart failure with preserved ejection fraction. So anything more than 50%, we know that it is heart failure with normal ejection fraction. In addition to it, we have ruled out infiltrating cardiomyopathies, hypertrophic cardiomyopathies, valvular heart diseases, pericardial diseases, and high output heart failures like anemia. So there are some mimickers when there is an associated kidney or liver diseases, then we are not including it as heart failure with preserved ejection fraction. So this slide I just put it to understand that any sort of evaluation of a heart failure with preserved ejection fraction, we should know these values. E velocity, anything less than 80 centimeters per second. EA velocity, EA ratio, anything more than 1.5 is considered abnormal. E dash velocity, anything less than 8 is normal, more than 15 is abnormal. Deceleration time more than 240 milliseconds is considered abnormal. So when we know about these 4 things in this diastolic numbers, we'll be able to identify or come to a conclusion that we are going to manage a patient with heart failure with preserved or infiltrated ejection fraction. So these are the different stages in the diastology of heart failure. So what is important here is, again, I'm going to stress on the point that, anything more than 15 at a stage 4, we ought to know whether it is reversible or it is irreversible. Once this is identified, and when we have a PA pressures of more than 35 millimeters of mercury, we know that, we are going to deal with something like heart failure with preserved ejection fraction. So to stress on what guidelines says that, the sensitivity pattern increases to more than 83% if the E bar E dash is more than 15. The European guidelines again says that, anything between 8 to 15 is also considered as a minor criteria. So the biomarkers are lower, and additional information is more necessary here. That is where this LA left atrial volume index comes in. I'll be talking about this in the next few slides. So again, this is a point to indicate that about the usefulness of the major and minor criteria. So these are the three, apart from the standard echocardiographic criteria, we have some comprehensive criteria to comprehensive echo parameters to know to identify it as well as to come to a conclusion that, we are dealing with a heart failure with a preserved ejection fraction. So three criteria: LV mass index, relative wall thickness, and LA volume index. LA strain pattern has also been included in the recent guidelines, which I'm going to highlight in the next slide. So how do we want to? It's not important how we are going to quantify LV mass. We have to take a couple of parameters like the posterior wall thickness as well as the LV dimension in diastole. The recent software has completely evaluated the LV mass. Anything more than 240 is considered significant and being taken as criteria for left ventricular hypertrophy. We are talking about the relative wall thickness. So why is it important? Because sometimes, we have something called as eccentric hypertrophy. We talked about concentric hypertrophy. We want to know whether is there any real hypertrophy. So a ratio of more than 0.4 is considered relative wall thickness. So any echo report with patient with suspicious of a heart failure with preserved ejection fraction should have a relative wall thickness also. So once this is done, then we go into the LV mass. I spoken about LV mass. So put together both relative wall thickness as well as LV mass, we come to a conclusion whether are we dealing with a left ventricular hypertrophy, or it is a athlete's heart, or it is an eccentric hypertrophy, or it is a previously detected heart failure with reduced ejection fraction, or it is improved and it is now in an improved heart failure. And that is the reason why LV mass index as well as relative wall thickness are important. So once this is done, then now we have LA volume index. It's very easy. Anything more than 40 ml without even an index body surface area is considered a dilated left atrium. Why is it very important? At any point of time, it might be having an injury relation, or it might be going into a chronic relation. So once we have the LA, we have the LV systolic thickness, relative wall thickness, we have identified the symptomatic hypertrophy. The other additional point is about the global longitudinal strain. So how are we going to have this global? There are some softwares. It is being we have it in the latest echo machines where we want to put some few. I'll show some pictures also, which we put it in the LV muscle mass. Then a global longitudinal strain, if it is less than 16, then there is some amount of diastolic heart failure. So anything more than 18, we are very sure that even though this global longitudinal strain has not been inside the guidelines for heart failure, but it's an additional tool. Still, we want to know whether there is any subtle form of heart failure with preserved ejection fraction. So these are the functional morphological biomarkers in sinus and atrial fibrillation. Again, highlighting the point importance of having an echocardiographic criteria for identifying a patient with heart failure with preserved PF. So once this we have identified that it is within more than 5 points, if it is less than 1 point, we are going to say that it is normal heart, and if it is somewhere in between 2 to 4, a functional testing is necessary. So it can be a diastolic stress test or an invasive hemodynamic test. Usually we don't do the invasive hemodynamic test. So a diastolic stress test. What is a diastolic stress test? So like our treadmill test, like our Dobutamine stress test, we do a Dobutamine stress echo. You're not going to identify any watermark abnormality. You're just going to put some Doppler pattern, a E velocity, a velocity, a tissue Doppler velocity. If both the E velocity and A velocity goes hand to hand, then we know that the compliance is good. So there is no evidences of a heart failure. But if the graph widens, if the E velocity goes up, the E dash velocity goes down, we know that we are going to deal with some sort of heart failure with a reduced ejection fraction. So now LA strain has been part and parcel of our guidelines now. Ashwin Venkatesan was a senior echo technician who worked with us at Satyasai Photography, and he was the major reason for including into the ESC guidelines way ago in 2016. And now, predominant teaching institutions also include the atrial strain pattern in part and parcel of any echocardiogram, and we're dealing with heart failure with reserved ejection fraction. So when we talk about left atrium, this is basically a conduit. So there is a reservoir to hold the lead. It is a conduit, and there is a moment of booster strain. So when there is a reservoir strain, you want to know about the filling pattern of the left atrium. When there is a conduit, you want to know how much it is going to empty into the left ventricle in early diastole. A booster strain is the ability of the LA to assess the contractile function of the LA. So these are the three parameters which by this one single slide will tell us about the LA function in a particular patient. So there's some red, yellow, and green markers which has been put. The software detected. So we know that this is a automatic or a semi-automatic way of including this, and we get a value of like how we say ejection fraction in the ventricle is 60%. We call it as the LA function is more than 40% is considered normal. And here also we can use a global strain. Again, the numbers remains the same, like more than 80 it is normal. So this is the utility of LA reservoir strain. So when in a patient with normal ejection fraction, more than 50%, we want to identify that, whether there is any evidence of diastolic heart failure. So we know that I already told we are talking about three standard echocardiographic parameters like E bar E dash velocity more than 15, 2.8 meters per second, and the atrial volume index of the report. Then there is some discrepancy. Then we go for the criteria. So the filling pressures, if it is normal, then we are rolling out. If the filling pressures are intermediate, then we go for diastolic stress test. If the filling pressures are elevated, then we know that it goes into a patient with heart failure with reserved ejection fraction. So what is the natural history of this patients with normal ejection fraction? 5 years mortality as high as 50%, because now we have very good tool for reduced ejection fraction. Slowly we have medications or improve the quality of life to improve. This probably might have reduced to less than 50%, but still, when identified later, this also have a mortality of 50%. So very high alarming data. So what are the demographic features which helps to identify that these are the patients who might have associated something like, the race, ethnicity, geographic region. African Americans are more to develop heart failure disorder ejection fraction. Asians, in contrary, the lead molecules and diabetes have an increase with heart failure disorder ejection fraction. Female sex is another potential risk for having a heart failure, hypertension, obesity, diabetes, atrial fibrillation, and almost 50% of the patients will have some sort of an intermittent AF unless a holter or a continuous monitoring proves to it. High prevalence of renal disease, sleep apnea, and associated CV is as low as 20% to 40%. So how are we going to manage this type of patients? Risk stratification, like any other treatment strategies and lifestyle modifications like hypertension, diabetes, obesity, controlling the rate. Either we have been only looking about the rate control now. If you talk about rhythm control as well. Management of CABCKD, reduce sleep apnea, role of exercise and weight loss. A huge management change in heart failure with maintained PF. So now we have two drugs. One is the SGLT2 inhibitors. So this class on indication, so I'm going to talk in the subsequent slides. Historically, medical therapy has necessarily failed in managing heart failure with preserved ejection fraction because of the demonstrable benefit with all the drugs like peptidogramm, sartans, beta blockers, nitrates, digoxin. But in this all, I'm talking about only with normal ejection fraction. But still, it's being used in most of our patients with heart failure with preserved ejection fraction also. So now we have two drugs which have been into the guidelines for the management for this heart failure. One is based on the Emperor Preserve trial, empagliflozin. Other one is the Deliver trial for dapagliflozin, close to 20% reduction in 40% reduction in mortality and 20% reduction in it's all absolute numbers in heart failure hospitalization. So now it's been so recommendation for heart failure with preserved ejection fraction. The first drug to be used has to be SGO2 inhibitor of choice. So we have to so apart from this, a sprint trial which has been proven to be beneficial in intense blood pressure control, especially in a high cardiovascular risk patient. So still we use all this first line management, ACE, ARB, regular receptor antagonists, RNA, and all those things. Beta blockers to control hypertension as well as heart rate, especially in symptomatic CADs. So with Deliver and Emperor Preserve trial, we all know that now, dapagliflozin or empagliflozin has to be initiated in any patients with a reduced ejection fraction. But even with preserved ejection fraction, we have some sort of an indication to use it. In conclusion, heart failure, preserved ejection fraction, 28% relative risk reduction, cardiovascular death or hospitalization, 30% reduction in heart failure. So this is again the guidelines. So how to treat the atrial fibrillation? Atrial fibrillation, we all know that it worsens the heart failure. So earlier we were all thinking that we had to control the rate alone. Now with increasing incidences of atrial fibrillation going into reduced ejection fraction, we have apart from the drugs, we also are subjecting these patients for a rate controlled either in the form of EP study and RF ablation. So, rate AF trial in particular with bisoprolol and digoxin. Digoxin fares very well. They favors more with rate control and thereby reduction in the quality of life. So, the benefit of digoxin, if beta blockers are not tolerated, has to be initiated. Unlike earlier thing that digoxin might not be much useful or it is etiological. Ablations are being tried or has to be the first line of management when the patient goes from preserved EF to a mid-range EF. There is a major indication for EP study and RF ablation. So the main line of treatment will be with aggressive diuretic therapy to reduce the intracardiac filling pressures, both at rest as well as during exertion. So what sort of a diuretic? So it is a loop diuretic. It all depends on the severity of the volume overload, whether we are using a diuretic at a sequential nephron blockage or at an acid level. So using to reduce the myocardial fibrosis, PAPAC trial, which has been proven to be only 11%. It's not been one of the very good drugs for managing heart failure, preserved ejection fraction, but still to reduce the myocardial fibrosis, a medullary receptor antagonist is being used. So taking into caution about the creatinine and potassium rise. So heart failure reduced ejection fraction again RAS ARBs in parallel heart failure trial. This is a trial which proved that even a heart failure with preserved ejection fraction more than 40-45%. Again, valsartan sacubitril is being beneficial in reducing hospitalization for heart failure. So in conclusion, sacubitril also did not result in a significant lower rate of total hospitalization heart failure and death among patients, an ejection fraction of higher but still being used for most of our patients. This trial did not alter the primary endpoint of heart failure. It also did not reduce the overall mortality, but reduce the rate of hospitalization both and by preventing heart failure. So we have other phosphodiesterase like sildenafil. These are very insufficient clinical data having any data that it will improve heart failure. Nitrate therapy is only to reduce heart failure, congestion, pulmonary congestion, and otherwise not much of role, especially only associated and associated pulmonary arteries. So, with treatment guidelines for the management of heart failure with preserved ejection, once the heart failure diagnosis is confirmed, treatment is diuretic management for decongesting. If it is more than 50% and prior HF or mid-range, we have to move towards a preserved EF. Exclude if the mimickers like associated liver disease and renal disease. Once this is done, we have to select the patients. For all the patients with eligible patients, we have to start on RNA, ACE inhibitors, mRNA. Once when this is done with more than 50%, then we have to consider managing all the comorbid conditions as well as the cardiac. So the first line of management is SGL2. Apart from that, we can add on a diuretic for decongestion, and the other drugs follows. So diuretics class 1 indication, only 3 class 1 indications: diuretics, dapagliflozin, empagliflozin, as well as management of etiology and comorbid conditions. So these are the drug dosage to initiate it as well as the target doses for the usual drugs used for management. So management of all the comorbidities is vital: atrial fibrillation, hypertension, CAD, type 2 diabetes, CKD, obesity, and sleep apnea. So major management involves treating all those comorbid conditions. So the last slide of mine is very important here. We use the phenotype B, where how to manage heart failure, obese, metabolic phenotype, arrhythmic phenotype like atrial fibrillation, hypertensive, and the vascular phenotype. So once this is being taken care and adding on SGL2, decongesting the diuretics, will be able to achieve most of the targets. Thank you for your patience.
Thank you for your elaborate lecture on this heart failure preserved ejection fraction. Any questions from the floor?